This is a 4-port manifold closed system fluid administration kit. You're probably going to have a 3-port at clinicals. I believe what is on the actual packs is a 3-port. I have this one here, so if you could use this one, then you could use the 3-port. I'm just going to add a line. It's not that big a deal. We have a 12 cc contrast administration syringe. These are here for a reason. Put your fingers in here, thumb in here to draw and inject. Don't grab it like this. Don't grab it like this. It's so you can use it with one hand. You may have to use 2 hands every once in a while to do kind of a small power injection, but you don't usually have to do that a lot. We're going to take our manifold, whether it's 2, 3, 4, or 7 ports, and I'm going to make sure it's tight. I've done this a few times, so the noises I want to hear aren't there, but you should hear a couple little taps there of the plastic going together really good. You want to be able to take it off to clear it out if you need to, but you want it on there tight. If contrast gets in between these hubs anywhere, just like on the assist inside this rotating hub here, and it would be on this part of the assist where it connects to the contrast line. After a while, that contrast will sit there and start to dry, slimy almost, and these will not connect until you get it all the way clean, or one of the connections would have to be fresh. That's usually longer cases or for the assist later in the day, but so we connect it really tight, and we have a rotating hub here too. So that part's together. Then what? So this is where it's going to be pretty close to what you're going to see. This part, and what's connected here. So we're going to say port 1, 2, 3, 4. This is going to be our transducer. I don't have a transducer. I'm going to make up a mini transducer, which we should have. They just don't make those yet, I guess. But we're going to pretend. So this could have an arm on it to turn also. Again, we'll see that later, and I'll just pretend. So what am I going to hook up here? It kind of depends on where you're at. I believe clinical sites are going to both do it this way, except, again, we'll pretend that one of these is not here. First one they're going to do closest to the syringe. It's going to be this one that's got 2 lines that come off of one. So again, I'm going to make sure that's pretty tight. It might kind of hurt your fingers at first when you first start doing this. If you do it for a little bit, it'll feel a little bit better. And if you ever can't get it off, you want to make sure you use your hemostats. This stuff will break though, so when you're tapping on everything, you do have to be careful. So this one's got 2 lines. It'll be a waste bag that is going to go off the table. It doesn't have to go off the table. It's got a place to hang on the side. We shouldn't really need it on the table. So we're just going to hand that off or put it over the side of our table, make sure it doesn't pull everything off. And all of this tubing is twisted up and kind of stiff sometimes. You can stretch on it. Some of it you really can't stretch. This one doesn't matter, right? It's going to a waste bag. We're just going to stretch it out so we can have some room here. Some of these you do want to be careful. The high pressure tubing, I'll talk about that here in a little bit. When you stretch it out, you just have to be careful. The other end of this one is going to be fluid spike. So this is like a bagagette that's on here. So if you're on the other side of the table helping somebody else throw a table, you would accept this and you would pull this and spike your saline bag of heparinized saline that would be just hanging on the side of the bed somewhere, a table. It's got a roller clamp on it, so these are up, it's free, and there's no compression on the tube. And then when it's down, it is compressed, and there's no fluid going to come through there. Make sure they're up whenever we're trying to get something out of it. So we're going to hand that off, or hang it kind of on the side of our bed. You're going to be careful because the spike does need to be sterile and stay sterile. Just don't take the cap off and lay it over there. So this side is going to be contrast. Okay, so we got some contrast. I'm going to go ahead and hook this up first. That way if I do lean that over the edge or lay that over the edge of the bed and I mess up, it doesn't all just fall off the table. Okay, so this is a reservoir chamber for the contrast. This is going to screw into basically it looks like if you cut this spike off right here, that contrast spike would be in, have a point to connect to. We would connect that off the table. A couple of valves here to keep anything from going back into the bottle. So if we ever have a contrast bottle that we're going to use more than once, you have to have some kind of valve in place because it is possible that blood could make its way back into the contrast. The spikes that we use, the connections we use should have some kind of valve or something to prevent the backflow or that bottle cannot be used for more than one patient. You've got a little float ball in here, if you can see that. When it's all hooked up and we squeeze it a few times, it'll pull a vacuum, pull some contrast in there, that ball will float up. As you're using contrast and your contrast starts to go down and down, that ball will float down and fall right down into that spot where it is right now and not allow anything to be pulled through. It'll pull a vacuum on that ball and it won't be able to pull the air out, because that would, if it had fluid in it, the ball would be floating. So again, I'm going to hand that off to someone and I'm making sure everything's tight. Got another tube here. So what we're going to do different on this one is I'm just going to pretend that this is another saline, and I'll tell you why you might do that. Again, this is male and female on these, so I'm going to go male to female on the Manifold. So I've got female going off the table. So again, I'm going to stretch this one out pretty good, just to make sure it stays off my table and out of view for right now. So again, I would hand this one off the table. We're going to say another pressurized saline bag. Practice. Pressurized saline bag. And then our transducer. Now it doesn't look quite so bad once we get everything out of our way. And then just to set this thing up, we'll go through how to clear it out, and we'll just go back and kind of, not quiz, but just kind of practice. So I got my banger, right? This has contrast label on it. I don't want to take that off. This is a dry table. So I'm just going to, this is my banger. This is my 20 cc syringe that I'm going to use all the time. I'm going to start over here. I call it an arm. You can call it whatever you want. So each connection point, I would have already checked to make sure they were tight. If this one was a waste bag, this one was a pressurized saline, my contrast syringe. If I turned this way, under pressurized saline, it's going to go ahead and just go. If it's not pressurized, I'm going to have to pull it. But just so you understand that it could be used either way. So I'm either pulling, or it's going to kind of push at me because it's under pressure. If it's under pressure, you can let go and pretend my finger's not over here pulling this. It could just, or let's just take my hand out of the way, and it would just go because of the pressure. Okay? You don't necessarily want to do that because you're just going to fill up that syringe with saline that you're probably going to have to clear out a bunch of it because you're only past one part right now. So what you do is you go ahead and a little bit of it come at you. You give taps everywhere all the way through the system, connection points, and you keep your thumb in here, and even though it's pushing on you, you use your own pressure to kind of keep it where you need it to be. Tap, tap, tap. Again, this one has a waste bag and a saline. If I push, it pushes a valve. So the saline is blocked off basically, and it goes to the waistline. If I pull, it blocks off the waistline and it pulls from the saline. The reason you could have this and then another saline line would mostly, I think, be, and I don't know if you would ever see this, but a good reasoning for it would be if we have a bunch of blood in here, right? We had a bunch of blood because we were in the body and doing whatever. We pull some blood out and we don't want to give it back to the inside the body for some reason. If we wanted to waste it, so we push, and now this whole thing has just like full blood all the way through here. These things look gross when they have blood all in them. Right? And they're nice and clear. They look good, and no bubbles, right? So, and bubbles are hard to see in the blood. Which is not, there's not going to be a lot of blood in this system. It just will back up sometimes. And so I've tapped. Again, I'm pulling, and I'll push to go out to the waste bag. The reason you could have a saline over here under pressure is to do your normal flushing, and then you could have this other saline just to clear out this system, because I could go saline and push, saline and push, saline, waste. If I pull, it's saline. If I push, it's waste. It's the only one of these. I mean, how many other ones do you see with two directions? So it's the only one you're going to be able to pull. This port is the only one, whichever one has one of these, with two sides, and push, pull and push. Okay, it's going one way, and going the other way. Kind of makes sense. Then we've got contrast. And again, I'm gonna leave it down so you can see, but I'm doing my 45. I'm gonna bang, bang, bang. Again, now I have another point here. Bang, bang, bang. I have a point here. Bang, 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 and then I'm gonna hit the actual syringe. Again, I'm not trying to pull as much contrast through as I can. I'm trying to just kind of pull it through and make sure I get bubbles. And so if I just hit it and I'm not pulling back, it may loosen the bubbles up some, but they're still just sitting there. So I've got to give a little bit of negative pressure to unlock those bubbles and hope they come up this way, right? Look how good that is, not one bubble. Go ahead, zoom in there. I bet you there's not one bubble in there. Okay, and then so let's just pretend that this is another saline line under pressure. So if I turn this, exact same thing, tap, 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 tap. Again, I'm going to kind of use my own force to keep it from filling all the way up. Okay, so now this is where you can kind of do some different things. I would clear all of this out first and then do this. So what we can do with this waste is we would have cleared some air out somewhere, right? These lines all had air. So there would be some air in here with our fluid, no matter what it was. You can do a couple of things. If you have a waste bag, you might as well just push to the waste bag. If not, you can always turn this whole thing up this direction, and I'm going to use the table to push against. So I'm going to go at this angle so you can see, but I would really be straight up and down. So I'd be like this. So again, don't look at my right hand. I'm just kind of pretending. I wouldn't have to hold it because the table would do it. So I would just push on the table, and as I'm pushing, I'm kind of clearing it out. So we would, if we had air in here, I'm tap, tap, tapping to get the air to go up this way, and then I'm going to tap all these points along the way. Tap, tap, tap as I'm pushing against the table. Hard to see this way. Tap, 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 and I'm pushing against the table, and it should be right. And then up here, it's just kind of going everywhere. So I would kind of put my finger over it. Usually, you don't push on it, or you won't be able to push anything out. If you have a waste bag, you're probably going to be expected to push toward the waste bag. If you didn't have a waste bag, though, that's how you could always clear that whole system out. So again, let's pretend I have a bunch of air in here. I've got to get rid of it. I could do the exact same thing. Tap, 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 so I'm getting my bubbles up. But if I turn this way, I can push to my waste bag, right? That's how you could clear the whole system out. Now, if that was all clear, and you did the transducer last, I'd come over here, I'm going to turn this on, I'm going to tap, 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 and this is going to be up this way, but so you can see, I'm going to tap, 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 fluid coming out this way, okay, and then when I get done, everything looks good, no bubbles. And you do have to be careful tapping on the transducer. You can break it. Even just the transducer is sensitive, so just the sensor you could bust. We go 45 to 0. Some people don't necessarily do that, but what it is if it's at a 45-degree angle, this piece of plastic that goes down in there and lets fluid go through, there's just holes, right? It just depends on where the holes are directing things. When it's turned to a 45, there are no holes exposed at all. So if I'm here, I have a hole over here, right? There's an arrow, 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 and then an off, like, and just think about it, it's an arm. It's like you're saying it's off, the arm's saying off. It's an easy way to remember it. So, and then on this side, it's going to be off too, because there's nothing over here. So arrows, right? So if I'm at 45, so there's a hole over here and a hole down in the plastic, down in here to let stuff flow. So there's a hole, and there's a hole down here too. If I turn it 45 either way, there are no holes that you can really expose at all. There's no way for anything to get to them, so that's why we zero it that way. No pressures could get in. So we zero it at the phlebostatic axis. If it's on the table, sometimes we call that table mount. I would just call that table top. But it's probably going to be somewhere in that valley of the patient's legs, just because of how people's bodies are built. But you'll figure out how to kind of do that. You could have this go off the table and do pole mount off the table transducer. You would just flush to the other person over there who would be clearing it out, who might set everything else up. The one good thing about those transducers is once you zero them, it does not matter what I do here, up, down, it's zeroed over there, and that's not moving. As long as the bed, on the actual bed should be okay because the patient's moving too, which is what you would want. If you have this regular transducer zeroed at this point, and then you move things up here, and then the doctor's holding it up here, if we're up off the table higher, our pressures are falsely low. If they're too low, they're falsely high because of the atmospheric pressure and all that sciencey stuff. Okay, so this is what it would look like zeroed and ready to go, except I'm not anything filled up yet, but I was just getting it zeroed. So now it's zeroed and I can kind of do whatever. I would just do all that to get it cleared, get it zeroed, maybe fill up with maybe 50% contrast and 50% saline. Kind of let that go. Probably not fill it all the way up because you can't aspirate. It just depends on what you're doing. So then that would kind of be ready, actually. Could have done that and then said, okay, zero. They'll zero it off the table. And then we would be here if we wanted to get a pressure. But and if there's another arm here, you'll have to turn that one to make sure there's no flow. But we'll deal with that when we have a transducer. So again, this would be basically ready to go. You can turn it this way and you're still good. If you think about this thing though, 45 degrees, tight connections. Don't hit it too hard with this. You can hit it pretty good. Don't be obnoxious about it, or it will break your syringe. It could break this syringe. It could break this. Be kind of careful here. So what would I do if I wanted to pull contrast right now? And they don't all use just contrast. They use 50-50 saline contrast mix. So that would be a good question to ask. You set this up somewhere before you get ready to have this syringe ready to be used all the way. You probably should ask somebody. If they don't tell you, do we use all contrast? Do you use 50-50? Mixing it with saline just dilutes it. It doesn't opacify the vessels as much, but it saves a little contrast. So it just depends on what you're doing. So if I want to get some contrast in here, I would turn here and I would draw back. What happens if I turn here and I just set this thing down? Time's just going to go by really slow because nothing's going to happen. It's not under pressure, so I'm going to pull. I have to pull. Okay. What if I wanted to waste all of that contrast? What would I do? Now again, you could have a different set. This could be over here. This could be over here. That we want the transducer closest to the catheter, and depending on the setup, if you just had 3 ports, you could just have a transducer. It could be saline, and then probably contrast. If you don't have a waste bag and you just have those 3, you're probably going to put contrast and contrast next to each other, saline and then transducer. The ones that you're going to see are going to be transducer, contrast, and waste saline. All right, what if I wanted to waste all of that contrast that I just pulled in? Turn. It's wasted. Boom. That's it. Okay, so what if I wanted to flush? Let's say, again, I'm using this flush over here for only to flush out this system, and this is my actual saline line. What if I wanted to run, something happened to that patient, and they crash, and we want to run some fluids in them? Literally just fluids to maybe get some volume up. Let's say you had a pigtail catheter in. Okay, that's the rotating hub. The rotating hub is on there, so when it's connected to the catheter, we can torque the catheter, and everything doesn't have to turn, right? And you would not want to have to turn this a million times in a case. And again, it's going to be on tight. The physician's probably going to make that connection. So if this was in the body, had a pigtail in, and we want to just run some fluids, what would I do? I'm going to turn that one this way, right? I'm running fluids in. I was saying it was already hooked up. Let's say we just hooked it up. Like literally you watched me do this. So we just went up with the wire, pulled the wire. I stuck my finger over the end of the catheter so no air gets in, just in case. I'm going to fake aspirate here, some blood there. I'm going to stick my finger back over here. I'm going to get rid of that waste syringe. I'm going to go here. I'm going to connect. Now what would I do? Of course, our angle. I'm going to aspirate. I made another connection there. Now sometimes they'll connect. They'll turn the fluid on and let it run. You've got blood pressure pushing back a little bit here. There's this principle where when 2 fluids meet, you cannot get air in between them, and you just kind of do it real fast. It scares me. I don't like it. So I say you hook it up and aspirate. Tap, tap, tap. This is a connection, right? No, you don't do those extra ones, but you know what I'm saying. I'm tapping through this whole thing, knocking bubbles loose. Then we would inject. What if you were injecting? So we were here. What if the doctor's like, well, here, you do it. So you've got it and you got your angle and you're paying attention. That is another good thing about this manual system versus an automatic system, is that in both systems, the operator is the number one device against bubbles, right? But with this one, you have to pay more attention. It's right in front of you. It's in your hand. The whole thing is in your hand. You have all of these connections. You're maybe changing contract. You have to really pay attention. The spotlights help to be able to see better. So we're here. You're at your angle. And the doctor comes on cine, and you're going to inject. So you're going to push, push, push. As long as it feels, you'll learn how much and how forcefully and all that stuff to do. You don't try to jam it in there all at once. You're just going to kind of give a nice push. So let's say I did that. What if you walked in right now and relieved me for lunch, and this catheter was aorta, it's pigtail. Okay, so you're like, okay, what are we doing here? We're not done yet, right? You're just relieving somebody. So you walk in and it looks like this. You look up at the screen, right? You see your EKG. You're like, okay, heart rate's all right. So now what? Where's our blood pressure? Can you see a blood pressure right now? I guess would be the question. This is the transducer, right? So for the transducer to work, you have to have fluid go into it, though. That makes fluid go to it. So if you look at this manifold, these arrows go different directions, right? And then the off. Again, the off, think about it like an arm. It's off this way, it's off that way. Also think about this side here as off. Just think about it chopping that arrow off when it's aiming down. It can't go anywhere. So you don't even have to think about that one. So for example, this one, arrow, 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 off. It's off this way, right? So we've got an arrow going this way and this way. This one doesn't count because it's going nowhere. So we have this way and this way. That is the direction fluid can flow. Which way is it going to go? It's going to go that way, right? Because it's coming out of the body and hit the transducer. It stops here. There is no continuation on this one. It wouldn't be if it was a transducer, and that's where our pressure comes from. So just like the assist, when injection is on or you're pushing, okay, so again, I'm pushing. Do I have a pressure right now? I'm injecting. Do I have a pressure right now? No, can't. Okay. Not at least from this transducer, not from this catheter. You could have another transducer somewhere else, but looking at these arrows and thinking about which direction. So what would happen if I did this? We would have saline that would go back because it would be pressurized probably. Okay, and then I could turn it off. What would happen if I did this? Not much. We've got contrast that is not under pressure, and we've got saline that is under pressure. Still got a valve over here, so it should keep anything from going in. It might cause some tension somewhere in the system, but no reason to really ever do that. Like I said, if you can do 4, you could do 3. Just think about which way are things going to go and which way should I not do things. We're only pushing towards a waste bag or towards the patient. Technically, if you're clearing out the transducer, you could push through here. There's also going to be another thicker tubing that has this rotating hub. If you see this, it's probably going to be hooked to something that needs to rotate. So a catheter. So this stuff, again, this stuff's pretty stiff. You want to stretch it out a little bit. So this is that high pressure tubing. We're going to keep this end because we're connect it to the catheter. This other end is going to go off the table to whoever's at the power injector. What the power injector is basically like a big syringe. Imagine this syringe is the power injector off the table, hooked up. This is kind of like a contrast syringe preloaded that, let's say, it would load inside here. Okay, so it would load inside here and then off the table. And this is just pretending. It would be at an angle. We would connect here. Okay, and then this would be on the table to us. We would have them manually or electronically push fluid to us to clear this fluid. And then we would aspirate. We would hook up. we would have them draw back manually. We would tap, 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 get these bubbles out. It's going to go back, 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 even to where we can get blood. Whoever is back on this other end at the machine will tap, tap, tap to get all those any kind of connection. And we're doing an LV. Could be a hand control. It just depends on how the setup is. Probably the physician, could be whoever's running the machine. And we would do the LV like that. Okay, so then we would, when we were done, we would unhook, cover it up to make sure no air can get in. Okay, we would take this off the table. Probably go ahead and do a little aspiration just in case, just to make sure. Connect here. What's the next thing I'm going to do? I would, and I'm thinking very specifically, I just connected here, so I'm going to go ahead and aspirate and tap all the way through here. Again, just to make sure nothing's here. Sometimes they'll go ahead and reflush everything, just to make sure, and re-zero even. Either way, we kind of make sure there's no air here again. Connect, make sure there's nothing there, so you have to aspirate. So then what? So now we're going to do an LV to AO pullback, right? So we did our LV, we had our systolic and our diastolic, did our EDP, did the LV, cleared everything out. When we do the assist, we'll clear the contrast out of the line. So that means hitting the saline button and just pushing everything that's in the line out to the patient out. So whenever we get our pressure, it's just going through saline. There's some things about that, but what would I need to do though to do an LV to AO pullback? What do I have to do? Or could I just do it? Pull back? LV to AO pullback, yes. But the purpose of an LV to AO pullback is to get the pressures, right? So I would have to have my pressure on. And I would see my LV waveform, pull back. Bam, case is done. Or some people do the LV first. I like the Manifold. You're doing something. You're moving your hands. You get to, do all this stuff. You're going to see one of two things. You're going to see transducer, contrast, saline waste, or these two could be flip-flopped and your contrast would be closer. I believe they're always going to put the waste closest to the syringe if there is a waste bag, because you don't want to be pushing waste in between any other connections. Again, just think about where the stuff goes. This is contrast, so nothing's going to happen until I pull. This is saline under pressure, so if I go here, it's going here. If I go here, it's going there. It's going out. If I do this, I got nothing. Nothing. I mean, I could open this arm on and it's hard to tell because there's not one on there, to keep fluid from going out, but really nothing's going to happen there. When we use fluids, it's easy to figure out how to do.